Dear Chairman, dear colleagues, thank you for having me today. I'm Luigi Pannone, I work at UZ Brussels in Belgium, and I will talk about depolarization and repolarization in Brugada syndrome. I have nothing to disclose. So actually the first paper that is describing these long fractionated electrograms in the epicardium of the RVOT in Brugada syndrome was from Nademani. And he described on the epicardium of the right ventricular outflow tract, as you can see on the picture on the left, these prolonged bipolar signals. And at the unipolar you can see that sometimes these signals appear as a covert type. And the ablation over this area reduces the ventricular fibrillation and the ventricular arrhythmias that follow up. And this is the paper that Pedro was showing this morning, and actually we know that slow conduction is the cause of prolonged fractionated electrograms, and this is the same as in the infarcted human heart. And why we see this in Brugada syndrome? Because we know that in Brugada syndrome we have fibrosis in the epicardium of the right ventricular outflow tract, as you can see in the histological picture on the right. And this is associated with the reduced expression of the connexin 43, and this explains the prolonged fractionated signals, as you can see on the left, and also the slow conduction in the epicardium of the RVOT. So slow conduction, of course, plays a role in the pathogenesis of Brugada syndrome, and this is called the depolarization theory. However, also repolarization might play a role in the pathogenesis of Brugada syndrome. This is a study from Hans Levich, when he used, as we can see on the left, an arterially perfused right ventricular wedge. So it's a preclinical model, and he blocked the potassium current. He induced the pattern, Brugada pattern, and also, as you can see on the left, he induced these prolonged fractionated bipolar signals. And as you can see in the AP1, AP2 endo, you can clearly see that the unipolar is a covert type with the gradient endo-AP in the repolarization phase. So he concluded that actually the repolarization heterogeneity between the endocardium and the epicardium plays a role in the pathogenesis of the pattern, of the Brugada pattern, and also of the ventricular arrhythmias in Brugada syndrome. As you can see on the right, he managed to explain the arrhythmias in Brugada syndrome as a phase 2 re-entry, so as a re-entry using this heterogeneity between the endocardium and the epicardium in the repolarization phase, so in the ST portion. And this is what we do at UZ Brussels, and this is the experience that we used to build up our paper. So thanks to Prof. Marc Lamer, we access the epicardium of the Brugada syndrome patient with the HD grid. We map the epicardium of the Brugada syndrome patient. And this is the first experience with the high density mapping. As you can see on the right, we see this is before Ashmalin, so the patient has no pattern, and you can see that the potential are absolutely normal, both bipolar and unipolar potentials. Then we give Ashmalin, and we do the mapping during Ashmalin, and we see that these potentials become fractionated, become prolonged, and also the unipolar, it changes, it becomes covert type. And then we move on, we ablate, and these potentials are gone. So we came up with this paper, High Density Epicardial Mapping Brugada Syndrome, and we tried to define the potentials associated with both depolarization and repolarization disease. And we call these potentials high-frequency potentials and low-frequency potentials. So as you can see on the left, this is the typical high-frequency potential. It's a potential, as you can see on bipolar, defined as a lava, so as a potential that is under the QRS or after the QRS, and with the typical local activation time. As you can see on the unipolar, there is a steep negative dV/dt under this signal. So it's a local signal. While on the right, you can see the typical low frequency potential. It's again a fractionated prolonged signal at bipolar, but the unipolar is completely different. It has a steep negative dV/dt followed by a concave unipolar. So it's like a Brugada pattern. And so we observed that this is a high frequency potential before Ashmalin on the left and after Ashmalin. So the high frequency potential after Ashmalin becomes more fractionated, more late, and this is expected because of the delay of conduction induced by Ashmalin. And this is the low frequency potential, again, before Ashmalin on the left and after Ashmalin on the right. And again, you can see that these potentials become more prolonged and more fractionated. And sometimes, as you can see in this picture, the high frequency potential are like a late potential, so after the end of the QRS, as you can see on the figure on the right. And we tried to figure out to explain these two potentials. So we used the ECG imaging, as Cinzia showed, is 252 electrodes, vest, and we put on the patient. It's non-invasive, and it can reconstruct the epicardial unipolar potentials. And as you can see on the right, we have the ECG imaging. So we look, and in the red we have the unipolar electrogram, and on the left the high frequency potential. First, we can see that the unipolar high frequency potential morphology is very similar to the morphology of the cardioinsight. And then we analyzed the activation time of the high frequency potential, and we compared with the activation time of the cardioinsight vest, and we saw high correlation. So we concluded that the high frequency potential are associated with disease in depolarization, so the slow conduction in Brugada syndrome, while low frequency potential can be explained by an heterogeneity in the transepicardial heterogeneity in the repolarization. And also we used the cardioinsight for risk stratification in Brugada syndrome. And actually RVOT activation time after Ashmalin and RVOT activation recovery in interval after Ashmalin, they were both predictors of previous sudden death in Brugada syndrome. And we also looked at the genetic basis of Brugada syndrome, and we demonstrated that patients with the genetic mutation of SCN5A, they have both a longer RVOT activation delay at cardioinsight and a longer high frequency potential and longer low frequency potential. Now, in the same number of heart rhythm, we see that also another paper from the group of Weisseger was published. And they described the mechanism and the effects of sodium channel blockade on Brugada syndrome. They did quite the same. They mapped with the epicardium with an ablation catheter, not an HD grid, so not an high density catheter. And they tried to explain this prolonged fractionated signal. So they did Ashmalin. And as you can see in the graph down, the letter B, you can see the ablation distal, the bipolar, and down the unipolar. And they see that there is a long fractionated signal, and with Ashmalin there is sometimes a conduction block, as you can see. So the late potential becomes later and then it blocks. When it blocks, we can see that at unipolar this is a covert type unipolar. So they concluded that both high frequency potential and low frequency potential can be explained by a simple conduction disorder, so a depolarization theory. And when there is a conduction block, this is a low frequency potential, so it's a covert type unipolar. Actually, this year, the Japanese group published this case report on European Heart Journal, case reports, and they used a unipolar recording using a bandwidth 0.05 100 Hz, and they looked at the epicardial potentials. And they built a decanav map of the epicardium with a subxifoidal puncture, and they reconstructed the anatomy and, of course, the potentials. As you can see here, bipolar 1, 2, 2, 3, 3, 4, and the unipolar signal from the mapping catheter on the epicardium of RVOT of Brugada syndrome. You can see on bipolar the prolonged and the late component of these potentials, and sometimes, as you can see the letter B, there is a block, a conduction block. However, as you can see in the unipolar, there is a typical ST-up with a typical Brugada pattern despite the block. So the block is not related to the typical unipolar signal. So they conclude that indeed delay in the conduction and block cannot explain all these features. And so these are the conclusion of the Japanese group. And indeed, the high frequency potential demonstrated a localized block, and this is expected, while the low frequency potentials demonstrated no change in the duration after pircicanamide administration. And so the convex type JST elevation remained unchanged despite the block of the late component. And so they concluded that indeed it's a complex physiopathology, and both depolarization and repolarization abnormalities might play a role. In conclusion, both depolarization and repolarization abnormalities contribute to ventricular arrhythmias in Brugada syndrome, and the hybrid epicardial ablation of RVOT targets both mechanisms. Thank you.